Uh, all right, so our first speaker is Professor Dr. Ismail Saiboon, who is a senior lecturer and also emergency medicine consultant from Hospital Chancellor Tuanku Mukris UKM. He graduated from University Malaya in 1994 and obtained master in orthopedic and trauma surgery from UKM in 2003. And he subsequently specialized in emergency medicine in 2004 from UKM, and then completed a mini fellowship program at Weiser University of Pittsburgh, USA in 2011. And he was then awarded certification for healthcare simulation educator qualification from SSH USA in 2015. And he is also the first professor in emergency medicine in Malaysia and the first Malaysian to obtain CHSE certification. So without further ado, I would like to invite Prof. Dr. Ismail Saiboon to deliver his talk. So Prof. Ismail, we look forward to your insights, and the floor is yours.
Okay. Bismillahirrahmanirrahim. Thank you very much, Dr. Wan Shami, for the very kind introduction. And well, thank you everybody for tuning in to this early Saturday morning, beautiful Saturday morning here in KL. And for the next 1 hour or so, or maybe not even 1 hour, maybe like 45 minutes, I will basically trying to enlighten you a little bit on the topic that was given to me, which is simulation in neuroemergency. Is it feasible? Okay, so now this is my disclosure and disclaimer statement. I do not receive any financial assistance for this talk. My talk might be biased because I'm the chairman for the Malaysian Society for Simulation in Healthcare, also secretary for the education in Pan-Asian Society for Simulation in Healthcare, and also a fellow of the Academy of SSH USA. But this presentation does not represent any organization views or stand, and this is totally of my own view, right? So I think is important. Now, I was asked to give this talk by Dr. Nasrina, I think sometime about last year, and then she said that this topic is simulation in neuroemergency. Is it feasible? Okay, what do you all think? Yes, is it feasible? Or no, it's not feasible? Okay, I wish we have a good interaction. If anybody can just use their mouse and then goes to the reaction, and then you can put up your hand if you agree if it's yes. Of the 21 people that in this webinar now. Hello. Okay. Well, fine. To me, I will not say it yes. I will not say it's no. I will say it depends on the situation, the simulation, the topics that you want to talk about. Okay. So this will be my content for today's talk. All right. It's basically on the what, why, how approach. This is what I'm going to do for today. Okay, first of all, what is healthcare simulation practice? Simulation is a technique which we're trying to imitate some real things or some state of affairs or some processes. So it's a process of copying or imitating. The word simulation originates from a Latin word which is simulatio or feigning or false show, and basically it moved to this word called simulaire, which is more like sounds like French or Greek, which means imitate or to make like, and finally goes into the English dictionary. I mean the English words called simulation. Now, so what is it? It is a technique, right, that creates a situation or environment to allow persons to experience a representation of a real life event. And why they want to experience these real life events is for that it is used for either practice, or is it for learning certain things, or to evaluate the actions or inactions of in that event, or we can use it for testing, or basically to gain understanding of the system, okay, or the human's action or interaction. So that is basically what is simulation is all about. And this is an important slide because I think it will basically get people in proper perspective. Now, simulation modality, there are basically a lot of simulation modalities. For some of you might think that simulation is just like the mannequin, but that's not it. That's not the only thing about simulation. So let me just introduce you. So the first modality or types of simulations is called role play. Okay, so we can have a verbal role play, something like this. You just can sit around and just act it out, or I mean, through verbal. And I think we in emergency have used a lot of this verbal role play. One of the good example is when we're trying to do our tabletop. So we don't really do actions, but basically we just simulate verbally of the actions or the communication between one person to the other parties. Now, there are also role play, but this is called acting role play, which is also another modalities of simulation where we act it out. It's not only just we sit there, we sit, we act it out. There is an interaction between people. So this is one type of simulation called role play simulation. Next, which is the common one, is called the part task trainer simulation. It can either be a simple part task trainer, something like this. If you can see here, there is this one part of the body, which is the head and the lung, and we practice intubation of that valve mask. So this is called part task trainer because it's one part of the patient to train person repeatedly of a certain procedure. Or we can have also what we call as a complex task trainer. This is an example if you want to do what we call this some complex procedures. This is where people do laparoscopy or endoscopy. You can do this kind of thing. So this is what we call as a complex task trainer, where there is a feedback between you and the simulator, but it is one part only. So it's called a part task trainer. The next or the third simulation modality is called a screen-based, or some people call it computer-based simulation. And this is something that I think some of us are also exposed to. We have a scenario and we play with that scenario, and we play it through a screen. And the screen can be either a computer screen, a laptop screen, or even a tablet screen. And there is a program, and this kind of simulation helps a lot in terms of developing our critical thinking, our decision making, while else this task trainer basically help us in terms of having a certain psychomotor skill. Now, the next type of modalities or types of simulation is called modeling. Okay, if you have heard about the word 3D printing, you can print a model and we can basically use the model to explain things, or you can use the model to train you how you will react to those things. You can print from a bone or even to as big I've seen as actually a one human body. All right, so you can print that. Next is called the electronic patients. Now, the electronic patients, why is called electronic patient? Because they use, there is a full body, not like this one is a part. This is called part, but this one is a whole patient, a whole body, and you use electronic to basically to run the simulation. It can be either which normally people can see this. And I mean, some of you might be familiar with the word SimMan. Some people use Matiman. Some people use the simulators of Apollo. And it depends on but it's generally called electronic patient, and it is for electronic patient simulation modalities. All right, where you can, it's good for you to train team training, communication, what call this non-technical skills, and so on. So this is simulation modeling, which is good for that. Next is the extended reality, the XR, and this is encompassing the VR, or virtual reality, MR, mixed reality, or AR, augmented reality. So this kind of thing, which is coming up very popular nowadays, is coming up, but there's still not so many. I mean, not many program to cater for this, but there's a lot of potential for this thing to develop. This is called the extended reality simulation. So these are generally all the common modalities in simulation, in healthcare simulation that we use for training, increasing our competency and so on. All right. So what is neuro? I think this is all of you are already since you're all from the team of neuroemergency. Is basically a emergency that deals with serious neurological condition that requires immediate medical attention to prevent life-threatening complication or to prevent deterioration. I think and in neurosurgical emergency, neuroemergency, cases like stroke, like infection, like meningitis, encephalitis, having seizures or epilepsy, fits, altered levels of sensorium, traumatic brain injury, or even others. This all basically will encompass into the thing called neuroemergency. And this is where this fraternity or this subspecialty basically revolve on. And acute neurological disorders, that is very serious condition characterized by high mortality and substantial cost, effect on patient care and treatment, and also the disabling sequelae, which is basically what I've mentioned to you, some of the common thing and that we showed you just now. But there are also some less common thing like acute polyneuritis, myasthenia gravis, and so on. Now, next, bring me to this thing is why simulation in neuroemergency training. Okay, can't we just do just by reading books, attending webinars, and that's all? Well, you can, but there are certain things that I think that are unique in neuroemergency that maybe simulation can give you an added value to that. Some of the key features of neuroemergency cases is actually basically it is time sensitive. So you need some early detection and early management or rapid management. There is a diversity in terms of these presentations. Okay, you need some rapid assessment and intervention for it. We have to have some sort of like a systematic approach. Like example, when we manage a stroke and so on, it should be a systematic approach. It also usually involve multidisciplinary approach involving not only emergency physicians, but also maybe involve neurologists, neurosurgeons, staff nurses, and other healthcare professionals. So good in terms of team training, and also the practice of neuroemergency. There's a risk of secondary damage, right? Like example, you have a traumatic brain injury. This is a secondary damage of that, and there is a potential for disability and death. And because of that, I think simulation training is good to master some of the procedural skills that is required in neuromedical training. Simulation also allow students to gain confidence and to apply theory into practice. And virtual reality and physical simulators are now is an important part of neuromedical and neurosurgical training curriculum in some countries. And based on there's a lot of we need a lot of deliberate practice, meaning that doing it again and again and again of the same procedures, but in a controlled space. We don't do it on the patient. So that is also why I think simulation is actually will give you an added value. So simulation allows psychomotor skills augmentation without putting patients or the students at risk, and simulation makes training more appealing. Which I think if you do one training, let's say management of stroke, and we can have a good talk about that. But that basically only stimulates your cognitive part. But what about the performance and the psychomotor part, and also the effective part? So this is where simulation training basically come in handy and basically can give an added value to neuromedical training. Now, these are some of the rationale to simulation-based training in neuroemergency. Because in simulation training, it's usually learner-centered, and basically we try to basically create a situation that is suited for the learners to learn. So it's tailored to each learner's level. It provides a realistic, safe, controlled, and reproducible environment to improve knowledge. Okay, you can have patient goes into stroke multiple times in one day, and basically how you can run and make them follow the same procedure all and all again. You can also give technical and non-technical skills, or including still situational awareness. You can train on communication. You can train on teamwork and leadership. And simulation tools allow multidisciplinary team, as I mentioned earlier. When you try to manage stroke, it's not only EPs who manage strokes. It basically come from the AMO in the front, where they can triage the patient quickly, goes into the precise zone or the red zone, or the red box area, where you can do further assessment, make a quick decision, and basically send the patient to OT, to what you call this CT scan, and the people in the CT scan have to basically how to react to that. So all of this, we are basically multidisciplinary in terms of management of that. So that's why I think it is important that simulation can be used, because simulation is a good tool for team training. All right. So how can we make the advantage? How can we take the advantage of simulation in neuroemergency training? Now, I think one of the most important things, simulation allow focus area training. This is actually one of the a good thing about simulation. You can basically tailor your training module towards what is the intended outcome that you want to achieve, right? Example. If let's say you want to basically manage patient with stroke, or even you want to manage patient with having seizures, all right. Hello, can you hear me?
Yes, Prof. Yes, Prof.
Because I was muted. Okay, so example, you want to train stroke. Stroke so is covered in ACLS, but by basically asking your people to go through ACLS training, it will not train on the focus area of stroke that you want to do. Maybe assessment of stroke, maybe the flow, the process flow of managing stroke is there. So in simulation, you can tailor-make it. All right. Simulation methods are applicable for basically emergency training on emergency situations. It can be focused on technical skills, okay? Like in neuro-emergency, we have lumbar puncture, EEG, or cervical ultrasounds, or transcutaneous Doppler, and all. So it can be focused to that kind of thing. It improves procedure and patient pathway, okay? If we have like stroke pathway and so on. And it allows you to train on non-technical skills. All right, so this actually some of these how simulation can be used in neuro-emergency training. Now, if you want to use simulation, now I'm coming to the how, because today we have the what, the why, after that, and now is the how. How you do that? Now, a lot of people maybe think that if you do simulation, just get the mannequin or just get the people, act it out and run. Well, it is not as easy as that. In simulation-based education, we have this framework of 4 phases and 9 components that basically we have to meet all of this in when we want to do a simulation-based education training. Now, I will go to each and every one, each of this phase. Basically, there we have this initiation phase, creation phase, execution phase, and review phase. Let's go to the first one, which is the initial phase, which is basically which has 2 components called analysis and formation. Now, before you take up, you said that, okay, we can do this through simulation. You need to go to this first. Analysis first, and then after that, form what are the learning outcome you want to do. So these are basically some of the questions that you have to ask when you want to do simulation-based training. So that's why when they say that, is it feasible? Well, the answer, it depends. It depends on whether when you do the analysis, it fits to your objective or not. If it doesn't, then forget about simulation. Now, the first thing is actually we want to ask is actually, what is the problem? What is the problem that we want to address, or what is the gap that we want to address, or what do we want to teach, basically? So this is the first question, and we have to answer this truthfully. Who to answer this thing is the people who want to do the training. All right. So let's say what are the training we want to do? Okay, because a lot of people cannot do the stroke score. So you want to, the aim is that the problem is actually unable to identify stroke score. Okay, or you say that the problem is people basically get confused in terms of the stroke pathway. There's a lot of delay in terms of the stroke pathway. Then that is the problem that, or the gap that you want to address. Now, next question you need to ask is basically what is the aim of this activity? Is it for teaching, or is it you want to test your system in the hospitals, or is it you want to do some assessment, or you want to do it as a research or as a system integration? You want to integrate this new protocol that you have created into this kind of thing. So that's we have to be very clear what's the aim and the purpose. And the next question is actually what is the outcome we want to achieve? This is actually important. You want to have your people perfect. Well, that's a very big outcome. In perfect means what? They're able to perform the skills. They have to follow the guidelines. They have to basically able to make a good decisions. So what outcome you want to do? So we have to tailor-make that thing into what we think that's what is supposed to be the outcome is intended. Now, next is actually who should come to the course. Who's the target group? Is it the EPs, or is it the AMO? Is it a nurse, or is it a mixed group? So again, we have to answer this. Next is actually, the instructional method or the tool. What is we want to do? How can we do it? Can we just do this thing with just simple lectures? If the answer is yes, and we can do it effectively with simple lectures, my advice to you, do not use simulation. It's a waste of time because you said that for this one, just lecture is enough. So that's good enough. Okay. So when we're deciding this, we have to know what will simulation give you an added advantage for you to do it through the simulation way. All right. And what are the types of simulation that you want to, which modalities that you think it is going to be good? Okay. Next is the most important question when you come to scenario creation is what are you trying to simulate? Okay, I will dwell a little bit later about this, but this is actually the most important questions apart from what's the problem. What we are trying to simulate, because when you simulate the wrong thing or the thing that basically not towards your aim, simulation tak jadi. Simulation will be a failure. All right. So maybe you need to discuss this with a simulationist or who could basically advise you what will be the right thing when you want to simulate of what or what are you trying to simulate. And finally, you have to have basically how you want to measure the outcome. Because doing a simulation training is it takes a lot of time and effort. It takes a lot of energy. Okay, maybe some money into this thing. So there must be a proper way of measuring simulation output. So that will basically what are the things that you have to consider in your audit or in your report later. How you're going to measure the output. So coming to this, what are you trying to simulate and for what? Now, as I said, training with simulation, you are basically you can tailor it to what you want. It is you can go on a focus area, not as a general. So, example, what you are trying to simulate? Are you trying to simulate the clinical features of a certain disease, or you want to simulate the process of managing that disease or that condition, or you want to simulate the vital signs of that patient for decision making and so on, or you want to simulate the environment. And each of the features that you simulate will have a certain aim. Example, if you want to simulate the clinical features, basically your aim is towards diagnose, making the students or the learners will learn about the diagnosis or about making decisions. If you want to simulate a process, is basically you want to see how familiar your team is basically with that process, regardless what I have a stroke or you have a process like we have like a STEMI network, but okay, well, that's not about neuroemergency, but something like that. If you have a process in something, you want to see, you want to test familiarity, whether they can follow or those kind of things, or you want to test about the knowledge about those that process, or even decision making. So or you want to simulate on the vital signs that you so that the people can make diagnosis, proper decision making, or just want to see whether their knowledge is good. And last but not least is the environment that you want to simulate, because maybe you want to test the system, how the system in your place, the inside too of that thing. All right. So these are the things which is important to be question need to be answered before you embark. Yes, I want to do simulation is for this. I want to overcome this problem. This is what I want to achieve at the end of the day. This I want to measure. I want to use the simulation way of this modality. And my aim is towards or what I want to simulate into the example, the process. All right. Now, okay, this is example what I said just now. If you talk about stroke, maybe what you want to simulate is the work process. or decision-making of thrombolysis, or performing certain screening tests. If you're talking about meningitis or encephalitis, maybe what you want to stimulate is actually the aim is to get the diagnosis. You want to test the diagnosis, or even the work process when patient have meningitis, how it should be, all right? Or you want to have them perform a certain procedures. Okay, epilepsy, example, if you want to simulate an epilepsy, maybe you want to do it for clinical diagnosis or decision process. If you want to stimulate a brain trauma, so maybe you want to think that the thing that you want to simulate is the work process leading to decision making, or maybe even X-ray interpretation, or you want to simulate of altered mental status, then maybe your aim is actually towards diagnosis, performing a procedure, or even communication. All right. I hope I don't confuse you more, but I think that's roughly what I'm. Why do you want to simulate, or what do you want to simulate? Now, after simulating is basically forming of a learning outcome or learning objective. And in this, basically, we want the learners to target learner because we're training for this thing. You have learners of varying levels, okay, varying professionals. We have EPs, you have neurological residents, you have the nurses, and so on. So when you write down the learning objective, you have to be very clear. This simulation training is for who, right, and for what. In simulation training, we have general and educational learning objective, and this should be identified beforehand. All right. A lot of people do simulation-based training without even have objective. They just think that I have something in my mind, I want to do this, but you don't really write it down. You need to write it down. And basically, for one simulation scenario play or activity, don't have to have too many LO. Just have between 2 to 3 LO. Okay, and you can use the SMART system as the specific is the learning objective that should be specific, measurable, achievable, related, and within the time of whatever training. And usually one simulation scenario, don't run it for more than 15 minutes. A good simulation scenario for education activities goes between about 8 to 10 or 12 minutes. That's all right? Okay, because a lot of people think that I want it real. This another issue. So actually, simulation is basically not to make it real. It's basically try to imitate real things, but for educational purposes or for the aim of that you have listed. Now next is actually we go to the next phase, which is the creation phase. And in this creation phase, again, you have two components, which is scenario creation and preparation. In scenario creation, there are four important elements that you need to consider. One, what is the title, which basically we have right from the beginning, who is the learners, and what are the learning objectives, and how we're going to assess them. After you have determined these four things, when you're creating a scenario, then how to proceed, how to create this thing. This is one of the way how you can do. There are many ways actually, but this is one of the way I would like to share to you. Is actually you have this checklist and you have to build according to this checklist. One, you have to have a story flow. Okay, so create the story flow. Some people got storyline, some people got serial progression. So you have to create how the thing that you picture in your mind, the progression of the scenario. Two is actually you need to build in the fidelity. Okay, now fidelity that you have to build in for the patient, or on the patient, on the clinical setting, and on the environment. I will tell you a little bit more on fidelity after this. Three, you have to see whether are you going to use actors, standardized patient, or so on, and if there is, how many of them, and what's their role. You have to, in terms of in your scenario creation, also you have to think about delivery methods and facilitation methods, because in simulation there are several delivery methods. You can do what we call a continuous to end, meaning that you start the simulation, you don't disturb it right up to the end. After that, like 10 minutes, then after that you stop and you do your debriefing and so on. Or you can do a pause restart technique where you go run the simulation, stop it after 1 or 2 minutes, or after one LO has been achieved, and then you start to give feedback or ask question, and then you continue from there and so on. So it's a pause reset. There is another technique called rapid cycle deliberate practice. So there's a lot of delivery methods that you can use. And then after that, you also have to build the assessment form. So when you are design and developing the simulation scenario, you have to also think of the assessment form that you're going to use. You can either use a global rating scale or you can use a checklist. And then again, The debriefing point, you have to basically bring up what are the debriefing point that you want to have, or you want to tell them, or you want to discuss with them. What are the pre-instruction that you need to do, and what are the pre-reading materials? Because all people come to simulation, they all have a different background, different levels of their what they have. So maybe you want to have everybody have start at same level. So they maybe something on pre-reading material or pre-watching material. And you need to test alpha and beta test the scenario before you run it. So these are basically 10 steps that you need to do in terms of scenario creation. Now, when we talk about fidelity, fidelity is basically defined as a degree of accuracy, okay, of those things that people see that represent that given frame of time that shows reality. In other words, how real it is lah, senang cerita. So fidelity equals to reality. Now, and when people say high fidelity, a lot of people think high fidelity, I use high fidelity, but actually they are not. So simulators is if you talk about the simulation, the fidelities of the simulator sometimes will bring high fidelity simulation, sometimes it's not. But I don't want to confuse you. But high fidelity takes into account user perception and representation of the real situation. Okay. And fidelity, with fidelity, if the people think of the user think that it is real, it will get a better engagement rather than we just say that, okay, this is a patient, he's having a stroke. Just imagine he have this. Just imagine he have that. That is not good fidelity. And so the user will engage it based on what he perceive. All right. So that's why we want to reduce the imagination to be used by the user by creating that thing that looks almost real so that he will engage it better. So a good fidelity will have a good simulation. And the three main factors that I said just now that contributes to the fidelity is the patient. So you have to build the patient or the disease as real to the real case. Okay. So example, you want to do meningitis. So you have to build the scenario of a meningitis as a real meningitis case. And then after that, you have to create the clinical setting. If you see him in the ED research room or ED yellow zone, so you have to create this environment of a yellow zone or an environment of a research room. Okay, with the monitors, with the props and everything. Unless you're doing an in situ simulation, meaning that you're doing the simulation exactly at the place where it is. And the third one is the environment. Again, if the surrounding of the thing, you want to get the people into the mood of that. I'm basically treating this patient or this SP in the research room. So you have to build the environment of the research room. Okay. So these three components, as I said just now, the patient, the clinical scenario, and also the facilities, the environment will bring up the play or the simulation into a level of deception. Now, if you increase the whole thing even further, it will goes into what we call absolute fidelity, which is reality, which basically I don't think we need to go until that level because the cost is too high. So we want to bring the imagination so that when they said high fidelity, it bring them close to reality, but it's not real. So it's just a deception. All right. Okay. Now, after creating the creation phase, we go to the execution phase, which a lot of people basically enjoy. In the execution phase, there are three activities or three components, which is pre-briefing, the simulation activity, and the debriefing. All simulation activity or all activity that you use simulation need to start with a pre-brief. So what is pre-brief? Pre-brief is basically a briefing and orientation. Briefing basically about the learning object, what is the objective of this activity, okay, what's the aim, okay, you have to create emphasize on creating a safe learning environment. So what are do's and the don'ts that the student can have to adhere. You have to set the correct and conducive learning atmosphere. Okay, maybe sometime we can do, you have, if you use observer, tell them we have observers as blah blah blah. And basically, finally, you have to tell them, okay, guys, I know this is just a dummy, this is just a mannequin, but you have to take it as though it's real, because the thing that we have able to set it to the reality is there. All right, so that is what we call as learning contract or fiction contract. And if you use a video, you have to say that we are taping you for this kind of thing. If not, you don't have to mention that. After briefing, you go to the orientation, and orientation, because not everybody are familiar with your setup. So you have to make sure they are basically orientated to those kind of things, get them used to it, maybe for a few minutes, and then after that, we can start the simulation. Then, bam, that's where everybody likes it. You have the simulation activity. Depending on the modality that you have choose, either you can use either using a task trainer, a part task trainer, or using a VR or extended reality, or using a team training, the electronic patients. Okay. So these are the things that you have to these are the things that they will go through. So they will enjoy this part of that simulation. Finally, after simulation activity, you come to the briefing. Debriefing is basically a process of collaborative, guided, reflective process, which is led by someone, a facilitator or educator. Now, from a study, about 65 to 75% of learning takes place in debriefing. Only about 25% to 30% of they learn during the simulation activity. So debriefing actually is a very important process that, all of you who are going to be educators or teachers or basically facilitators or instructors have to be familiar with this debriefing technique. I think it's a bit too short for me to dwell so deeper into debriefing, but I think suffice to say that debriefing is important. You have to basically be able to master this thing, and it is more of a guided reflective. It's a guided reflection, okay, that foster clinical judgment and critical thinking of the learners. And it is not the same as feedback, because feedback is basically you are telling them this is what you did right, this is what you did not right, and so on. But this is where in debriefing we want to see from the students, or from the student point of view or the learner's point of view, why they do that kind of thing, why they do the bad thing. We don't say the bad thing, but why you do that, why you do this. So we want to see what is actually their thinking process. Okay, so we have to encourage their reflective thinking process. We want to explore the emotion before we give, before we decided to give or not to give the feedback on that. And finally, after this execution phase, we come to the last phase, which is the review phase. And the review phase, there are two activities: reflection and evaluation. We want the learners to go back and do reflection. We have done the guided reflection during debriefing, but we want them to sink in so that whatever they learn will stick in better. So they need to do reflections. And after that, we also need to do evaluation on the learners, how they did. If you have do the checklist just now, the assessment, we can do the learners, and also on the scenario, because not one scenario is perfect. We have to basically, again, evaluate whether what went wrong with this scenario, why the student are not achieving the LO that we have intended to be. So, so these are the things that we evaluate in simulation training. The strength and the weakness of the training, what are the things that we can improve, and what are the solution that we can do to improve the quality of the simulation. And evaluation includes assessment of its impact on both the trainees and the patient care. Now, if you heard about this called Kirkpatrick model, you can use the Kirkpatrick model in evaluation. The Kirkpatrick model has 4-level reaction, meaning that, so at the end of the course, we usually give them a feedback form, and the feedback form said, how do you think of the lecture? How do you think of the food? How do you think of the lecture room? So that is basically only a level 1 of level 1 Kirkpatrick assessment, which is just to see their reaction to it, say, or do you like it or not. Now, if you, at the end of the course, you do a test, you have a pre-test, you have a post-test, that is where you go to a second level of Kirkpatrick assessment, evaluation, whether they learn or not, whether they learn something or not for this kind of thing. The third level of Kirkpatrick model is behavior, whether they translate, whether the behavior that they learn during the course able to be translated during work. And this is normally when we basically give the feedback form, to their bosses, and ask the bosses to evaluate whether this fellow able to do this during work and so on. And last but not least is the results. Why the boss sent this fellow for the training. So whether it able to achieve what is the overall aim of this thing, whether it improve, like example is stroke, whether it improve the whole stroke system, whether it improve the door to balloon time, or whatever you want to talk about that. Okay. Sorry, not balloon time. The what do you call this? The door to thrombolysis time. Or you can do also the thrombectomy thing. So it depends on what results you want to achieve. So that's the last thing. that's what will be the best level, the fourth level. If it achieves the result, meaning that your simulation training for that module is basically having excellent results. Okay. Now, what is the future direction? I think there's still a lot of unmet needs for developing and implementing simulation methods in neuroemergency training. I think still a lot of things needs to be done. And the inability to reproduce the clinical neurological features or something will be the limiting factor. But I think with near future, we can improve on that. Either with we can use the VR, or we can use a better simulators, or even we can train the SP to do better. But as long as you focus to what you want, something you don't need this. And thirdly, simulation modalities used in healthcare have continued to expand over the years, including with high and low tech mannequins, with screen-based or computer-based simulation, and with virtual reality. I think it shows a very promising for a fully immersive simulation setting in the field of neuroemergency. So coming back to the question that was posed to me in the beginning, simulation training in neuroemergency, is it feasible? No. What do you all think? Can I have some feedback, please? Do you think it is feasible? Yes? Okay. Or do you think it still depends? Well, to me, it still depends. It depends on how you take this kind of thing. So, this is a little bit on this, finally, the message I want to leave you with. So these are some of the areas that you can do simulation. And these are some of the things that I think you need to build your simulation module for training. And I'm happy to help if you have any issues on what to simulate and how to do it. You just feel free to reach me out and reach out to me, and I can try to help in whatever way I can. With that, I thank you.
All right, thank you very much, Prof. Ismail, for the enlightening presentation. So we will now open the floor for questions. You may type in your questions in the chat box, or if you prefer, you can unmute your microphone and ask Prof directly. So I've got one question in my inbox. It's not really related to neuroemergency, but more to general questions regarding simulations.
Okay.
So he asks, can we adapt simulation training in those emergency department with limited resources, such as in district hospitals where they don't have all that high-end mannequin and such?
Yeah, yes. Well, to answer that question literally, the answer is yes, it's possible. As I mentioned to you, we have many modalities in simulation. You can do, if you don't have any money to go with that thing, you can do the verbal or the acting simulation using the SPs, the standardized patients. So you can do that kind of simulation. And with that simulation, you can practice on communication with the patient. You can talking about, de-escalation therapy. You can talk about managing violence, or you can talk about taking consent. So that kind of thing is actually all simulation-based training, and you don't need any simulators for that. So it's a very low chip for the thing. Now, if you want to do something like CPR, and if it's in the low which is which is cheap, then you can pinjam, you can borrow. I think there's a lot of places that can allow you to borrow this kind of thing, which is what I did last time when I was in Moore Hospital. We don't have much, so we borrow from JB and we borrow from Malacca for training. Myself and Dr. Mahata, we were doing the airway training at that time for our MAs and nurses. So we borrow the thing, so you can do that also. All right, so that are the things. So if you don't have anything, my suggestion is actually either you borrow or you do the acting or the SP's type of a simulation.
All right, thank you, Prof. So second question is, What are the commonest barriers that you have dealt with so far when you try to implement this simulation-based training?
Okay, I think for me, the biggest obstacles actually people don't understand simulation.
Mhm.
They have different mindsets about simulation, and then the thing that simulation is expensive. First they don't want to try simulation because they think simulation is always expensive. As I mentioned just now, you must know all the different modalities and which modalities you can use. Actually, screen-based simulation also is cheap sebenarnya. A lot of simulation. I mean, apa tu apa program yang ada kan in the internet, you can download, you can play with that. Alright. Um, so people don't really understand about simulation. I think is the biggest thing. And when they buy a simulator and they just use a simulator, this is also another issue, because if you just use the simulator without a proper, I mean, all the 9 elements of this simulation, it will not last long. These are the thing. After a while, you can buy, because okay, I've traveled a lot and I've seen a lot of places. Usually they got a lot of money lah. Some places get few millions, beli macam-macam lah, beli kan all those thing eh. Tapi bila dia tidak ada module or a training program to tie to each of the simulators tu dia tak jadi simulators, dia hanya jadi toy, permainan. Macam kita belilah Barbie doll kan, katalah belikan untuk anak Barbie doll. Dia tak ada manual kan apa nak buat dan sebagainya. So yeah, people will play. After a while dia kata, well, dah lah, cukup lah. So these are the thing. This is actually one of my biggest challenges, actually, to go around the country and basically try to educate people how to use simulation correctly, and you can make full use of simulation. If not, simulation akan jadi banyak gajah putih lah. Kalau nak kata contoh gajah putih, mungkin tak payah sebut lah kat sini lah kan. Tapi saya rasa banyak tempat lah you can see simulation end up as a white elephant. That I think has been my biggest challenge, getting people on to use the simulation correctly. And when the people don't know how to use the simulation correctly, but they don't want to learn, that's another. Macam ni lah, ultrasound lah, katakan ultrasound ultrasound. Oh, ada ultrasound yang paling canggih, boleh buat 4D lah, everything. Tapi tak pernah belajar kan, untuk tonyo, lah tak dapat buat, buang. Macam tu kan, contoh tak payah. So these are the thing lah, pada saya lah, that's my biggest challenges.
All right. Thank you, Prof. Ismail, for answering those questions. And thanks to our audience as well for your participation. We will now proceed to our second speaker.
All right, thank you everybody.
Thank you, Prof.